Welcome, everyone, and thank you so much for being here today. I'm Brianna, the Vice President of Clinical Sales here at Galaxy Diagnostics. And many of you joining us today work with complex cases every single week. Cases that don't follow the expected trajectory, cases where symptoms persist, cases where standard answers don't fully explain the clinical picture. Vector-borne pathogens often live in that gray space. The chronic, the unexplained, the cases that challenge even the most experienced clinicians. And when those cases show up in your exam rooms, the question isn't just, what test do I run? It's, what am I missing? When traditional answers don't bring clarity, deeper investigation becomes more than optional, rather. It becomes essential. At Galaxy Diagnostics, we believe that advancing patient care starts with a deeper scientific inquiry. Not just running tests, but asking better questions, looking beyond surface explanations, supporting clinicians who are committed to understanding the full biological story. And that's what today's conversation is all about. It is truly an honor to introduce to you all Dr. Edward Breitschwert. Dr. Breitschwert is internationally recognized for his pioneering research in vector-borne disease, particularly Bartonella and other stealth pathogens. His decades of work have fundamentally expanded our understanding of chronic infection, diagnostic limitations, and the complexity of host-pathogen interactions. In addition to his academic and clinical contributions, Dr. Breitschwert is also a co-founder of Galaxy Diagnostics, a reflection of his commitment to translating research into meaningful clinical application. His research has challenged assumptions, it's reshaped clinical conversations, and continues to influence how veterinarians approach difficult, unresolved cases. What makes his perspective especially valuable is that it bridges rigorous scientific investigation with real-world clinical relevance. He doesn't simply study pathogens, he studies what they mean for the patient sitting in front of you. To our Galaxy partners on this call, thank you. Your commitment to deeper diagnostics and thoughtful clinical decision-making is exactly why conversations like this one matter. Before we begin, just a few housekeeping notes. You may submit your questions at any time using the Q&A tab, and we will reserve time at the end of this session for discussion. Dr. Breitschwert, we are honored to have you with us today. We're ready when you are.
Thank you, Brianna. Can you hear me?
Yes, we hear you perfectly.
Perfect. Thanks, everyone, for joining us for the monthly Galaxy Diagnostic webinar. And since we have a fairly ambitious schedule, we'll go ahead and get started. And this webinar will be available subsequently on the Galaxy website. And there's quite a bit of detail in some of these slides, which you'll be able to review at your leisure. What I'm going to do today is highlight 10 clinical cases involving Bartonella species, demonstrate some of the diagnostic limitations associated with conventional testing, provide the clinical response to targeted antimicrobial therapy that was prescribed by the attending physicians, illustrate emerging One Health implications, and as many of you know, I'm a veterinary internist, and my approach to this is that these organisms that infect animals also infect humans through many times the same flea and tick vector, and then reinforce the need for advanced diagnostic testing using enrichment culture and molecular workflows. So the major theme of this seminar is, why is Bartonella missed diagnostically? And there's a number of reasons that hopefully will be clear to you at the end of the seminar. To start with, the genus Bartonella is composed of fastidious, low-abundance stealth pathogens, and experimental infection studies that we did in cats using blood from donor cats that had actually induced neuroretinitis or classical cat scratch disease in their owners demonstrated that these cats develop a intermittent bacteremia, and depending on the Bartonella henselae strain that we injected, that bacteremia was even unpredictable in a research setting. As you'll see from the case presentation, serology is frequently discordant, and standard PCR, qPCR, which we've used for decades, is not sensitive enough in many instances to say yes or no, there's Bartonella DNA in a patient sample. We've tried to do on a research basis, and certainly now on a diagnostic basis, is to enhance our ability to confirm this infection using enrichment culture and advanced digital PCR technology. So initially, we're going to start out with case presentations, And the first case presentation is a young girl infected with Bartonella cholerae. And for each of the 10 case presentations, there'll be a reference at the bottom that you can refer back to if you want to review aspects in more detail. So this was a 18-year-old woman actually from the Raleigh-Durham area that whose mother contacted me because her daughter had a 4-year progressive illness. I think the other thing that's become apparent is that a lot of our vector-borne diseases have associated gastrointestinal symptoms. And in this instance, the young lady was diagnosed with celiac disease during this 4-year period and even prior to developing her neurological symptoms. Initially, it was just pretty much teenager with depression and anxiety, but then it progressed to severe headaches, muscle spasms, joint stiffness, reduction in tactile sensations, hallucinations. And interestingly enough, when she related those hallucinations to me, she indicated that sometimes in her dreams, she would feel like there was actually a cat that was attacking her, and then peripheral vision loss. I've tried to emphasize on the slides in which we've included tables from the actual publications is what I will emphasize in the context of the presentation. And then, as I said, you can refer back to it. If we look at the 13 horizontal line, what you'll see is when we initially tested this young lady, we did not have a Bartonella cholerae specific indirect fluorescent antibody assay. We had isolated Bartonella cholerae from cats, and it is another flea-transmitted Bartonella for which cats are a reservoir. And we did not detect antibodies to Hensel A, Quintana, or our 3 Vinsonii Burkhoffii genotypes. And initially, the PCR from blood, serum, and 7 and 14-day cultures were negative, except for we got a positive on that 14-day. But at that point, we still could not amplify enough DNA to sequence it and say what was wrong. So this was essentially reported out at that point as a negative. As fate would have it, we had then developed a IFA test by March of '09, and we went back and started testing some of our human IRB study participants. And what we found was this young lady had Bartonella cholerae antibodies, but as you'll see, consistently did not seroreact to the other antigens that we were testing against. She was then determined to be PCR positive on the very first sample that we got, as well as on subsequent samples from blood or enrichment blood culture with Bartonella cholerae. She was treated by Dr. Chris Woods, infectious disease at Duke University, who I've collaborated with over the years. And as you'll see on this slide, she experienced a complete clinical recovery. I should mention that early on in her treatment, she was not compliant. So initially, she was treated with doxycycline rifampin. Subsequently, Chris changed to rifampin and azithromycin, and we got a little better compliance. And as you saw in the previous slide, she seroreverted to a negative state and to a PCR negative state. So the importance, I think, of this case is that it really took directed serology to tell us that there was something there, and then modifying our PCR target to the fact that it was exactly Bartonella cholerae that we were targeting to be able to amplify enough DNA, sequence it, and prove that she was infected. The second case that we'll talk about is a small cohort of individuals with malignant melanoma. And how this story came about is I received a phone call from a dermatologist in practice in Oregon, and his question to me was he had run Bartonella serology on some of his patients, and they had come up positive. And did I think that Bartonella could play a role in regard to melanoma? And obviously, the answer to that question would be I really have no idea at this point in time. So in August, all 8 of these patients were actually Blood was tested through my IRB study. 7 of the 8 had evidence of Bartonella exposure or infection. 3, we managed to document Bartonella henselae DNA in my lab in the blood samples that were sent to us. And in 2 patients, subsequently, Dr. Bemis in Minnesota documented DNA of Bartonella henselae actually in the tumor itself. Those 2 tumors were obtained approximately 4 years earlier, earlier prior to our doing the blood testing. And then Marna Aronson at the University of Minnesota demonstrated, as we'll see on a subsequent slide, the presence of Bartonella within the tumors. So I think there's a lot of detail on this slide in regard to each of these 8 individuals. I think the most important summary is down at the bottom. Overall, these were elderly individuals that had multiple health conditions with comorbidities, including diabetes, hypertension, hypercholesterolemia, heart disease, depression, and breast cancer. So what this dermatologist was impressed was that these tumors that were most often associated with areas in which there was a lot of sun contact, he was in a state where there's often not a lot of sun, number one, and number two, these individuals did not have occupations in which they had extensive sun exposure, and the lesions were occurring in areas in which the sun shouldn't have touched. So on this slide, we'll go quickly through a lot of information that's in the publication, but what I wanted to point out is in the orange block to the upper left in the table is that we and others have demonstrated that there's 6 Bartonella henselae strains that infect cats, dogs, and humans in North America. The strain is most typically used by commercial diagnostic companies for documenting the presence of Bartonella antibodies is the Houston 1 strain obtained from an AIDS patient in Houston, Texas, and it's the type strain in the ATCC. But what you'll see is that if we had only used that particular antigen in our testing, all of these patients would not have had antibodies, whereas 4 of them did have antibodies to Bartonella henselae S8, which is a strain we most often find in people who are actually ill, and in animals that are actually ill with one of the Bartonella henselae strains. The photograph below that depicts staining of Bartonella in melanoma cell cultures. That would be panel B. The production of vascular endothelial growth factor, and to date, Bartonella is the only organism that's known to stimulate the production of VEGF and cause endothelial cell proliferations, which it also did through these melanoma cells. And then section D is very interesting because it's actually a stain that lights up the lymphatic vessels. And why I think this is important is there's been tremendous emphasis on Bartonella on the vascular endothelial side, but as a clinician, particularly in what I've seen in dogs, I'm very concerned about Bartonella also being able to invade lymphatic vessels and cause unusual lymphatic presentations that we've certainly experienced in dogs and have seen in humans. And then the slide on the right just basically said we could go to in vitro cell culture with imaging and document that the Bartonella was not only extracellular, but it appeared to actually be able to invade melanoma cells. I would add that that's not perhaps unique in as much as Bartonella, unlike many of our tick-transmitted organisms that only infect neutrophils or monocytes, seems to be able to invade a vast majority of cells that researchers have looked at across multiple tissue types. So I think the key lesson here is that Bartonella may play a role in the tumor microenvironment, and as many of you know, there's been tremendous emphasis on finding DNA of bacteria, viruses, and other organisms in association with breast cancer and other tumors. So there's a lot of work that needs to be done to sort out what all that means. The next case is one of our veterinary dermatologists here at North Carolina State University that saw a large breed dog that had rapidly developing tumors over its body. In the process of aspirating one of those tumors for cytological evaluation, the dog did a big jump and she managed to put the needle into the meaty part of her hand. What's important in this particular case is that in the vast majority of cases that we've been involved with, I can never figure out exactly when or how the person became infected. Obviously, many times there's smoke, that there's been a flea infestation or a tick exposure or some other potential mode of transmission. But in this instance, we were able to start testing within 5 days of this needle stick occurring. What you'll see here that I want to emphasize again is the specificity in which early infection occurs, and this has been documented when we've experimentally infected cats or experimentally infected dogs, that they will actually make a very specific response to the strain that they're infected with. In this instance, the veterinarian managed to infect herself with Bartonella vinsonii burkhoffii, which is a canine adapted Bartonella. And you'll see that she did not seroconvert to genotype 2 or to Bartonella henselae to any degree, not up to a titer of 1 to 64 that we consider the lowest titer of clinical relevance. But she did seroconvert to the two genotypes that we either amplify from her or from the dog, and presumably this dog was infected with two Bartonella vinsonii burkhoffii genotypes. I think for me as a clinician trying to understand infectious diseases, one, you'll see, as we've all been taught, that PCR is more sensitive in the early stages of disease. Here, we were able to get a positive PCR for Bartonella vinsonii burkhoffii on post-inoculation day 34. By day 81, she had a titer of 1 to 32, but if you look at the table, the next data point we have is day 90 some, and she's now up to a titer of 1 to 128. So it took this veterinarian literally almost 3 months to seroconvert to the Bartonella that and probably two genotypes that she managed to inoculate. She developed migraines early on, and then when she began developing a sensory neuropathy, Chris Woods agreed to treat her at Duke, and she was treated with doxycycline and rifampin and had complete symptom resolution, declining titers, and fortunately never looked back. The next case is a case that supports the possibility of perinatal transmission of Bartonella from the mother to the child. And one thing has become very obvious to me in trying to understand this genus of bacteria, and that's the fact that Bartonella, one, can hide from the immune system better than most of the other vector transmitted organisms that we've studied over the years. Two, and its goal is not to continue kill the host or, as some people have suggested, burn down the house that it resides in. So this woman was actually scratched by a cat a couple decades before she got married and before she became pregnant. I would emphasize that she had problems becoming pregnant and had to go to in utero fertilization to become pregnant. And clearly, we discuss in the manuscript the fact that there's good evidence from animal models of Bartonella interfering with reproductive performance. What is remarkable is that she and her son and her twin that died at 9 days of age were both infected with the same genotype, Bartonella vinsonii burkhoffii genotype 2, and the same strain of Bartonella henselae, as I mentioned earlier, the SA2 strain, being the one that we most frequently find in a sick animal or human. So what I want to emphasize in this table, and again, I realize these tables contain a lot of data, is the fact that both the mother and the father, both of whom may have been infected literally for decades or years, were seronegative to both Bartonella henselae SA2 and to Bartonella vinsonii burkhoffii genotype 2, which both were confirmed in their blood or their enrichment culture by PCR amplification and DNA sequencing. So as I mentioned earlier, there are discordant results, and I think the good news for Bartonella serology is based on what we've done in my laboratory is it is highly specific and doesn't cross-react with a lot of other bacteria. In other words, we can use serum from dogs or humans that have extremely high titers to Ehrlichia, to Rickettsia, to Lyme disease, Borrelia burgdorferi, and there's no cross-reactivity. But the problem is sensitivity, and a negative serology does not rule out the infection. So the fact that we could amplify and sequence Bartonella Vinsonii burgdorferi from brain and liver tissue of the child that died at 9 days of age from the son and the mother 10 years later, and we only got Vinsonii burgdorferi out of the father, suggests that there was transmission occurring within the family and likely in utero transmission to the children. I think, again, as I mentioned earlier, and we've generated some recent studies more related to what we're seeing on reproductive performance in cats infected with Bartonella henselae, even as reservoir hosts, that this is an area that requires some funding and some substantial study. The next couple cases, what I'd like to emphasize is actually vector awareness. And what I've stated at some national and international meetings is, as far as I can tell, Bartonella is transmitted by more vectors than any other known pathogen, and I haven't had anyone correct that statement. It may not be correct, but at least as far as I can tell, it is, and no one has corrected it yet. So as all of us know, sandflies, the human body louse, and fleas are probably the three major vectors for Bartonella transmission worldwide. But red ant transmission and pigeon mite transmission and rat mite transmission have been reported. And the case I elected to emphasize was a family in Kentucky where the mother contacted me because the youngest son was being seen by a pediatric neurologist, Dr. Sarah Hopkins, who's a co-author on this particular case report. And what that son had developed was Guillain-Barré syndrome, which we've also seen in a couple veterinarians now infected with Bartonella. And it had progressed to chronic inflammatory degenerative polyneuropathy. And during the period where all this was occurring, the older son was developing behavioral changes that were atypical for him, and the mother fatigue, headaches, and cognitive dysfunction. So what they had experienced was this woodlouse hunter spider infestation in a apartment that had flooded, then became infested with woodlice, and the hunter spiders apparently prefer woodlice as their daily diet. So again, as you'll see in some subsequent cases, the good news is the parents took pictures of the lesions that occurred on the children. Obviously, these are pretty nondescript raised papules. And again, unless someone reported spider bites, I think it'd be hard pressed for any of us just seeing the lesions, if no one knew what had happened, to know what might have happened. What I want to emphasize in this particular table is the fact that despite the fact we were never able to confirm infection with Bartonella henselae SA2 in the boy with Guillain-Barré syndrome, he did have the highest and most persistent antibodies to Bartonella henselae San Antonio 2. And then the other thing that I would emphasize to everyone is we have, on a research basis, pretty much required a triple draw, because if a patient is infected with Bartonella, I don't want my research laboratory missing that. And we know that Bartonella induces this relapsing bacteremia. And if we look at the orange panel under the direct extraction as an example, you'll see there's a lot more negative PCRs there with the different serum DNA extractions, blood DNA extractions, than there are positive. And so we got two positives out of the mother, one in which we could only amplify it and say it was Bartonella henselae. The other, we could get a longer sequence and say it was SA2, as we found in the son. Why that's important is after we generated the results in the family, The father went back because they had left that flooded apartment and moved into a house, and he collected woodlouse hunter spiders. He turned over every piece of wood and stick he could find in the neighborhood and sent them to us, as well as some wood lice in the area in which this little outbreak investigation occurred. And what you'll see again is our ability to document the same Bartonella henselae and the same strain type in both the spiders and the woodlice. So prior to this publication, my reading suggested that spiders were never thought to transmit an infectious agent. And this obviously little outbreak study doesn't prove that spiders were the mode of transmission, but it certainly provides some smoke suggesting that it might have happened. So uh, I think the most important part of this study is Dr. Hopkins, after this, had been treating with IVIG. The reason we got involved is the frequency of IVIG administrations had increased and the response to therapy was decreasing. Once she treated with antibiotics and she elected to use clarithromycin and rifampin, the boy had sustained neurologic improvement and went back to having full neurologic competence. So the next case, young man with pediatric acute onset neuropsychiatric syndrome. And in this case, it was actually the father who contacted me because he was absolutely convinced that his son had to have some biological basis for having gone from being an honor student, very active teenager in a number of clubs and activity. His sport was fencing, and all these things had gone away. So at this point, he was a 14-year-old boy that rapidly developed a sudden onset of psychoses. He was having hallucinations. He had both suicidal and homicidal ideation, and his parents were now sleeping, one parent with him and one parent with his younger brother, out of fear for both of their children. The IFA was tested in a number of laboratories, including our own. And again, there was no evidence of antibodies to Bartonella henselae, which this boy was infected with. And he had received extensive psychiatric and immunologic treatments. What the time course was between October 2015 and 2017. There were multiple hospitalizations. He was taken to a out-of-state clinic for an 11-week stay in which he had extensive specialty evaluations, including EEGs, MRIs, lumbar punctures. He was subsequently, after that, diagnosed with autoimmune encephalitis. And then in January 2017, he was seen by a physician whose nurse identified stria-like lesions that I'll show you on a subsequent slide. And that initiated the investigation as to whether this could be a Bartonella or Neurobartonellosis case. Once antimicrobial therapy was administered, his psychoses resolved, and he has sustained his clinical stability to the point that he is now graduated from undergraduate college. I think we can look at his treatments and hospitalizations on these two slides. This was very detailed data that was part of a log that his father maintained on his son. And you can see the pink represents the period of psychoses, the yellow in which they felt that various things were improving, and then the green once these psychotic symptoms had cleared. On the left, it's primarily the specialists who were managing this young man, and on the right, it's the various antipsychotic early on, antidepressant, and other medications. And then once we get 3/4 of the way up, you'll see that antimicrobial therapy, which actually both targeted bacteria and protozoa, were administered to this young man for a very extended period of time while his attending physicians watched and monitored his improvement. So these were the lesions on his leg and axilla that prompted testing for Bartonella. And we'll come back to this in a little bit. We had previously published a case report that depicted these lesions, and many physicians who were seeing patients prior to those publications had suggested that these stretch marks or stria-like lesions might be caused by Bartonella. So that is kind of how the Bartonella component of this acute onset neuropsychiatric syndrome came together. But he didn't get involved from the standpoint of research testing until after 6 weeks of doxycycline administration. And I actually just finished doing a consult for a veterinarian taking care of a dog with Bartonellosis. And I mentioned what I have said in other lectures, that doxycycline as a sole antibiotic may substantially improve a patient infected with Bartonella, but it is highly unlikely to eliminate that Bartonella if the patient's immune system wasn't going to do that on its own. So monotherapy in this boy, actually for 6 weeks, we still were able to document the presence of Bartonella henselae in his blood and enrichment blood cultures. And again, with treatment, his cutaneous lesions completely resolved, as did the neuropsychiatric symptoms. Those two previous cases then caused us to go back through our records and look where someone had mentioned seeing a dermatologist. And then prospectively and retrospectively, we looked for patients that reported the onset of neuropsychiatric symptoms and the presence of various unusual skin lesions. It didn't take us very long to identify 33 individuals that fit those very loose criteria. 80% of the individuals with neuropsychiatric symptoms reported the development of concurrent dermatological findings. PCR was positive in many of the seronegative cases again, and as you'll see, digital PCR markedly improved our ability to indicate the presence of Bartonella. So when this represents 22 of the 33 patients in this particular study. If you go to the manuscript, there's a continuation table, which we did not include in this presentation. But I think the important thing to emphasize here is that it required enrichment culture. And if you look at the column within the yellow brackets, you'll see that qPCR was only positive for one individual, whereas digital PCR was positive after enrichment culture. And again, this is enrichment culture for 7 days, 14 days, and 21 days. So both of these represent 3 testing time points for both qPCR and digital PCR. And many times, as you'll see later, a patient will only be positive in culture at 7 days or 14 days or 21 days. Again, this is not an easy infection to document on a molecular basis. But when we combine enrichment culture and digital PCR, it has certainly enhanced our ability to do so. So I decided to put in a box for that particular table is really the most common symptoms that physicians see and patients report in association with documented Bartonella infection. And sleep disturbances, insomnia, cognitive dysfunction, which is mostly described by patients as mental confusion, and memory loss are the major things. And they're certainly the major things if you look at our early publications that we found in young to middle-aged veterinarians that are at higher risk of acquiring Bartonella. These would be the symptoms that these 34, 43-year-old veterinarians would say was literally making them feel incompetent to practice veterinary medicine. And I don't think there's any question anymore as to whether Bartonella causes neurological symptoms or neuropsychiatric symptoms. The question that we all need to answer is how often that occurs. So underneath the table is another example of these stria, or what have been referred to as Bartonella tracts. We've used the term Bartonella-associated cutaneous lesions, saying that we're not documenting for sure that they're caused by Bartonella, but they certainly go away if you treat the Bartonella. On the upper right, these are more snake-like lesions that are seen in some patients, serpiginous type of lesions. And then I think more unusual and perhaps associated with all of the physicians that believe that mast cell degranulation syndrome is a very important component of Bartonellosis and some of our other vector-borne diseases. These plaques are occurred in this young woman, which would be dysgraphism, without her having to touch or even scratch the skin. So I assume that that stimulation caused a rapid degranulation of mast cells in that type of cutaneous lesion, which unusual, at least in what we've been involved with to date. But most of us were taught in medical school that the skin can have cutaneous manifestations of systemic disease. And obviously, that's true with Lyme disease. It's true with ehrlichiosis. It's true with Rocky Mountain spotted fever. And it's also true of Bartonellosis. The difference is Bartonella may be able to cause a slightly broader spectrum of cutaneous presentations than we associate with those other tick-borne diseases. So don't ignore the skin, which my medicine residents prefer to do. I'd like to end with some of our recent studies on the complexity of co-infections, which, again, I think many of you on this call appreciate the tremendous medical complexity of both diagnosing and then, more importantly, being able to treat and eliminate these co-infections when they occur. The first case is with Dr. Amy Offutt, and it's a case of autism. It is the only case of autism that we've been involved with, and it was a teen that had learning disabilities. Again, standard serology was negative, and ultimately we proved that this boy was infected with Bartonella quintana. Like the father in the previous publication, the mother did an amazing job of maintaining a computer diary with all of the various symptoms in her son. So she and Dr. Offutt put together these two tables, and obviously green is good, red is not good, and yellow is better. And what you can see is that prior to the onset of the diagnosis of autism, which included different diagnoses of attention deficit disorder, pediatric acute neuropsychiatric syndrome, Tourette's, and Lyme disease, this boy didn't have many of these symptoms despite having a degree of cerebellar hypoplasia at birth. And then you can also see that despite having a congenital neurological abnormality, his symptoms improved over time with directed medical therapy. So we also tested the mother and some other family members, and the mother was actually infected with a different Bartonella species. At least that's all we were able to prove. And she strongly believes that she was the source of infection for her son. And again, this required, which I didn't show the tables, which are in the manuscript, multiple digital PCRs to tell us that there was something there, and then species-specific ITS PCR to prove it on a basis. This is another case report that I really think is important, and I think it's important in the context of co-infection, but I also think it's important in the context of now having data that says Bartonella can persist in the brain of a child for at least 6 years. So the story here, again, is a mother who contacted me because her child was scratched on the face at 2 years of age, and at 4 years of age developed refractory seizures. At 8 years of age, when I was contacted, the neurologist, based on the single hemisphere disease, suspected Rasmussen's encephalitis, and we'll look at the diagnostic data later. Thank goodness for cell phones, because the mother took a picture of the scratch, and I would emphasize this scratch occurred by a feral cat in Canada in the winter north of Toronto. And although we believe that fleas have to be on cats, and flea feces have to contaminate the nails of cats to be injected in scratches, that may not be 100% true, because I'm doubtful that even a feral cat would have fleas in that part of the world at that time of the year. And then this child develops another lesion on the hand. And so I'll let you refer back to this story, but what we were able to show and was initially on the table on the left, we did not detect antibodies in January 2022 when we first tested this boy, and we did not detect anything by qPCR, digital PCR, and enrichment culture. The mother insisted that brain biopsies that were obtained for ruling in or ruling out Rasmussen's encephalitis be sent to us. Dr. Ricardo Maggi put these into two culture media, and rather than testing at 7, 14, and 21 days, we tested those media every 3 days. Multiple cases, the media became digital PCR positive for Bartonella. And in a couple instances, we had enough DNA to amplify and sequence and say that there was Bartonella henselae in the brain. Presumably, the lesion at 4 years of age that precipitated seizures, status epilepticus, and numerous emergency meetings was due to a co-infection with Babesia oticolii and Babesia divergens MO1, which we were able to document in the original blood sample that we had never tested for Babesia, in the brain samples, the brain cultures that we were sent, and in subsequent blood samples that were sent to us. So the importance of this study, in my opinion, is one, this child likely was infected for 6 years when the Bartonella entered the brain is somewhat, and how it got there from that facial scratch is somewhat anyone's guess. But then a second vector-borne organism transmission precipitated within 2 weeks minor motor seizures, which within a month were generalized seizures and status epilepticus. And so our last case report is a family outbreak study. I labeled this as a One Health family outbreak study because it actually started with a family, and then during our investigations involved the dogs, one of whom developed a cancer that we've been studying. And it is a true argument for One Health in the fact that we need to look particularly at vector transmitted infectious diseases as to how they're occurring in humans, how they're occurring in animals, and what the environmental risk factors are for the transmission of these pathogens. And what you'll see, to our absolute amazement, so this family is a mother, a father, a son, who was the initial contact because the son had developed another PANS-like presentation, and then 2 daughters. So we've got 5 individuals. Every individual in this family, including their 2 pet dogs, were infected with Bartonella quintana, which should not occur inasmuch as Bartonella quintana is thought to only be transmitted by the human body louse, and humans are thought to be the only reservoir, despite the fact that we've amplified it from cats and from humans bitten by cats, and others have amplified in Europe Bartonella quintana from cat fleas. So I think we have the preferred vectors, and I think we have other vectors. Bartonella henselae was documented in 1 dog, fleas, and 2 of the children. Bartonella divergens, MO1, was documented in the entire family, along with Babesia microti. And I think, again, when you start trying to get this type of data published, the first thing the reviewers are going to say is there must be contamination in this laboratory, or Brightsworth's laboratory doesn't know what it's doing. And I can assure you, I don't think that's true. But I do want to emphasize the complexity of what we're doing on a research basis and what Galaxy is trying to offer you on a diagnostic basis. And it's depicted in this diagram that we won't go through, but what it means is from every sample, from every triple draw that we get from every patient, we're doing at least 15 different PCRs at the outset. And so it's a very complex algorithm to be able to generate the DNA sequences that I'm sorry, that we included in this particular report, which are analogous to the DNA sequences that I showed you for the young boy up in Canada. So it's not just that we got a positive PCR result. We actually got a chunk of DNA. We sent it to a commercial laboratory, GenWiz, who generated a sequence. They sent the sequence back to us, and we confirmed that that sequence from that particular sample, many times repeated at different times in our lab to prove that we could do it more than once. So I think this is another important outbreak in as much as the initial young boy was tested because of neurologic signs and a suspicion of Bartonella, not Bartonella quintana. We found more than one pathogen in the family, and what the family actually did because of the neuropsychiatric symptoms in the dogs is they started rescuing dogs from the southeastern United States and bringing them in kind of for facilitated care for their son, which was not a good idea because they ended up with all kinds of veterinary illnesses. Plus, they may have introduced some other things into the family that were part of what we were finding by our testing. So my final thoughts before we take questions is that as I mentioned, I think Bartonella is an important cause of neuropsychiatric and neurologic diseases and certainly deserves increased research funding for us to be able to confirm that. There are very distinctive stretch mark-like cutaneous lesions, and this has been criticized by some human dermatologists as being a farce. I do not think it is a farce at this point in time and deserves some more consideration and research. These bacteria induce a chronic and relapsing course that can span years and decades. Co-infections are frequent and oftentimes may reflect infection with different organisms at different points in times, as we illustrated with the young boy up in Canada. Serology is often negative. Standard PCR, unfortunately, is not sensitive enough to detect these Bartonella in many instances. And I think the clinical takeaways are think Bartonella an unexplained neuropsychiatric illness, look for those skin clues, take a good One Health exposure history, which I realize is a bit challenging, but any vectors that a person reports they've been exposed to should be somewhat suspect, and help Galaxy Diagnostics and others to continue to prove diagnostics so that we can do a better job at taking care of patients. With that, I thank you very much. I want to acknowledge my team here at North Carolina State University for their research contributions. The guy on the left is Dr. Ricardo Maggi, who's worked with me on Soft Money and is the Chief Technical Officer for Galaxy Diagnostics for 22 years, and Dr. Jen Miller, the Chief Scientific Officer for Galaxy Diagnostics. And I can see, when I look at this picture, all I can say is I really don't like having my picture taken. Thank you very much.
Thank you so much, Dr. Brightshort, for a great presentation and going over these cases. With that, if we have any questions, go ahead and raise your hand or stick them in the chat to submit. But I will say, oftentimes, Dr. Brightshort, I get asked, we talk about triple draw as the best approach when we're trying to look for Bartonella. As you've clearly demonstrated, this is a difficult pathogen to be able to find. Do you find that serial testing also improves the detection for Babesia as well?
Yes. And I think I'm going to preface that by saying one of my PhD students, about 25 now, a co-faculty member, a full professor, and an internist that works with me. So we have worked on Babesia in animals for a very long period of time. And when Adam joined our faculty after finishing his PhD, I said, you take the protozoa and I'm going to stick with the tick-borne bacteria. And that's the split we made. But because of the Cohen Foundation funding, we initially developed Bartonella digital PCR, and then we were asked to develop Babesia, Borrelia, and Bartonella digital PCR and validate it. And so that's what we did. And honestly, there's other publications that we did not cover today. There is another publication that we'll submit tomorrow. And I only mention that in as much as what we have found relative to Babesia divergens, Babesia oticoli, and Babesia microti to a lesser extent was totally unexpected and amazing to me. And I think we collectively need to rewrite the textbooks as to what constitutes chronic human babesiosis. But we're seeing the same trend is that the more samples we test and the longer it's in enrichment culture, the more likely we are to get a PCR result that we can put a DNA sequence on.
Okay, fantastic. So you summarize your takeaways, right? That it can affect the skin, it can affect neurologically. What other organ systems that you see are commonly presenting as possible Bartonella infections?
Well, I think there's two other big categories. One is rheumatologic disease, which was not included at all in our discussion today, other than I think the young lady with Bartonella cholerae complained of joint pain. But if you go back and look at early studies that we did, particularly with Dr. Mosiani, those studies were very much biased by rheumatologic patients. And I actually think that there's more interest amongst rheumatologists currently in starting to think about what Bartonella may be doing in patients diagnosed with rheumatoid arthritis and other rheumatologic conditions. The second area is certainly where Bartonella almost started, and that's endocarditis. Bartonella is considered the number one cause of culture-negative endocarditis in humans and the number one cause of culture-negative endocarditis in dogs. I think one place in veterinary medicine where we're a little ahead of our human counterparts is that Bartonella not only targets the valves, but it also targets the myocardium. And we have reported myocarditis in cats, myocarditis in dogs. And these are usually very severe terminal cases that have very severe granulomatous myocarditis. But I think, like all diseases, you identify the most severe cases first, and then you realize that there's others in which Bartonella is causing conduction defects and other problems associated with the myocardium and conduction system that you're not going to do a biopsy and find a lot of granulomatous lesions.
Thank you. We do have a couple of questions in the chat, but we have a hard stop at 1 o'clock. So I'm going to just summarize some of the answers. For those of you, if we don't get to your question, please submit it to contact@galaxydx.com and we'll make sure that we get you an answer. But what we are seeing in the chat is that there's a lot of questions about fish testing. And what we're doing here is digital PCR. So to get into a longer conversation of this diagnostic versus this one, what I will say is that there are no head-to-head studies that are comparing a fish assay with digital PCR in these stealth pathogens. While both of these tests are great tools to have in your toolbox, it's really difficult to compare apples to apples because these are apples and oranges. Both are direct tests. Digital PCR is a quantitative assay. Fish is a qualitative assay. Keeping it broad, Dr. Breischer, is there anything else that you would add with the differences? I think where clinicians really get stuck is when do I use which test when? If there's anything you'd like to add to it, by all means. But for those of you asking those questions, I'm more than happy to dive into the more of the technical differences on a one-to-one. So go ahead and email that contact@galaxydx.com and we'll get some things set up. But Dr. B, anything you would want to add on that?
You did a great job, and I've always been of the opinion that if you live in a glass house, you should never throw a stone.
This is really tough science. This is emerging science. Yes, we've spent a lot of time studying Lyme disease over the last 40 years, but a lot of these other pathogens, we need more science. And Galaxy is definitely trying to partner with different clinicians and different cases so that we can learn more from you guys to continue to iterate and make better diagnostics. But we're definitely still in progress, as we'll say. Thank you so much, Dr. Breitschwer, and I hope all of you have a wonderful day. Take care.
Thanks, Brianna.